Hello, hello, is the voice audible? Just let me check quickly. Hello, yes, I think the voice is audible. So, today we are going to quickly revise and try to finish the topic of glaucoma under 2 hours. So, I would actually apologize that the clock is not working because the OBS streaming software keeps shutting down because of my supercomputer. So yep. So hello everyone. Mm, Let me just check the stream. Yep. So let's begin the topic of glaucoma. Mm, so today is the basically so today is basically the third day of the 30 days series of studying before MB. Okay, just let me. Okay, so let's just uh, 1 second. Yep. Yep. The chat box is open here. Just. So glaucoma. I hope I'm audible to everyone. And let's see. So right now the time is 6:09. So in 1 minute I'm going to start this topic, and let's not wait anymore. Okay, the streaming is doing fine. Let's see. Brave. Oh, Brave is not working. Yep, Brave is now working. Okay, so yep, so glaucoma. So let's just wait for everybody to join right now. I'm just going to check the. Why is the slide not changing? Oh, what seems to be the problem? The slide is not changing. Why? Just a minute. I'm just going to. Yeah. So yeah, the slide is changing now. So let's start the topic of glaucoma without any further waste of time. It's 6:10 already. So yeah, so glaucoma is basically the definition. Just let me. Uh, okay. So yeah, glaucoma. So the definition of glaucoma is basically it's a group of disorder leading to chronic progressive optic neuropathy with characteristic changes in the optic nerve head and visual field, where the increased ocular pressure is a significant risk factor. So this is the important thing, that in glaucoma the basically the definition is a group of changes where number one, it's a progressive characteristic optic disc change, and number two, it's the irreversible visual field change. Okay, so acha, let me just for 1 second give the link to everyone in the group. So yes, so So that's the definition. Let me say it again. It is progressive characteristic optic disc changes and irreversible visual field changes. Now, IOP may or may not be increased, but IOP is a very significant risk factor of glaucoma. So that's an important thing. Increased IOP, which means increased production, which is rare, like dropsy glaucoma. Increased resistance of the outflow is the commonest cause of raise of IOP, and then the increased episcleral venous pressure, where also known as Sturge-Weber syndrome. So, okay, I hope the stream is doing okay. Yes, so increased episcleral venous pressure, which is Sturge-Weber syndrome, uh, carotid cavernous fistula, thyroid ophthalmopathy, okay, and features. So before starting the features, let me just quickly adjust the slide once a bit, which is I think now the time should be visible, if I'm not wrong. uh, just a second. Hmm. So yeah, the slide is visible and the time is also visible, I think. Just let me edit this once a bit. Okay. Hmm. Now it's visible, I think. Yes. So basically, let's see the features. Features of uh, the features of glaucoma. So the very important thing is IOP. The normal range is 10 to 21 millimeters in mercury, and the measurement is obviously we'll come to it later, but just let's see the overview of the measurements, like indentation method by most commonly the shear tonometry, applanation method by Goldman tonometry, which is more accurate, so it's considered the gold standard. The Goldman is gold standard. So yeah, this is the basically the overall features of IOP and how the measurement is done, but we will learn about this more specifically in the coming slides. So the important thing is pressure effect on the nerve fiber, because we have seen that glaucoma is basically two things: optic disc changes and visual field changes. So now these two changes are a resultant of the increased IOP. So here the mechanism exactly is the IOP increase causes increased pressure on the nerve fibers. So basically mechanical effect. So pressure changes causes damage to the nerve fiber, especially arcuate fibers. Arcuate fibers are basically this one. Let me just try and show. So yeah, if this is the optic disc, then this is the PM means papulomacular bundle, and the arcuate fibers are on the temporal side. So the superior fibers are known as superior arcuate, and these inferior arcuate fibers on the inferior temporal half. And on the radials, which on the nasal side, we have basically the superior radial and the inferior radial. So remember this, the important point is the fibers which are closer to the optic disc are actually the thicker fibers. So like the radial fibers are more thick as compared to the arcuate fibers. So the thinner fibers are more commonly affected by the pressure changes of the IOP. So basically the arcuate fibers are more vulnerable to IOP changes. So and also there is another leading theory as to why these visual field changes occur. So that is basically decreased perfusion of blood, and which causes decreased exoplasmic flow, like that causes the ganglion cell death, and so death by apoptosis. And also, like, we are just starting the basics, so we need to just have an idea of the fundus. So this is the fundus image of, probably everyone can guess right now. So that is the left eye. Left eye because the optic disc is on the nasal side. So here the nasal, it's on the left. So on, like, imagining as the observer's view, so this is the left eye of the patient. And yes, so this is the symbol diagram where the common thing to note here is physiological cup. ঠিক আছে, তো physiological cup basically is the smaller part where the vessels of the retina enter the eye. So this is an important concept, and the whole of the outer whitish thing is known as the optic disc. The full thing is known as optic disc. So the outer periphery is known as actually the neuroretinal rim, where from the name you can guess that all the retinal nerve fibers actually go out of the eye. So basically the central part is the cup where the vessels exit the eye, exit or enter, and the peripheral side is the neuroretinal rim. So actually we are going to learn here that in glaucoma the peripheral in increasing of the pressure of the eyeball, where the intraocular pressure increases, the pressure effect actually comes on the optic cup, and the size of the optic cup becomes larger compared to the whole disc. So we are going to study in the coming videos that yes, so we are going to study that the cup, a specific thing known as the cup is to disc ratio is going to change. So yeah, so raised IOP is a risk factor for glaucoma, and optic disc examination is done by, so this is basically the ophthalmoscopy image. Visual field is done, tested by perimetry, and IOP is measured by tonometry. So these three are basically the important three ocular examinations corresponding to the glaucoma. So yeah, I have discussed the mechanical theory and the ischemic theory, and now flow of aqueous humor. So just before starting the flow of the aqueous humor, let's see the changes in and around the disc. So yeah, here the important features to note is basically enlarged cuppage to disc ratio, which is more than 0.7. Then the asymmetry in the cup disc ratio beneath the two eye. This is also suggestive changes of the glaucoma. And localized notch or thinning of the neuroretinal rim, as I mentioned, which is important. Now the vascular signs like bayoneting sign, and now we'll see in the coming slides that what the bayoneting sign means, and bearing of the circumlinear vessels and laminar dot sign. So these are the basically characteristic glaucoma findings. And splinter hemorrhage at the disc margin, which is also found very commonly, and nerve fiber layer defect. So these are the, and the parapapillary atrophy. So the atrophy of the retina around the optic disc is known as the parapapillary atrophy. So these are the common changes in around the disc. So in glaucoma we have to actually see for these specific changes to actually diagnose, and we even try to stop this progression of this gradual disease. Yes, so we have to prevent not the IOP change, but the result of the IOP change, which is these defects in the retina. Okay, so here are some of the images, like enlarged cup is to disc ratio, where we can see clearly that the inner side, I don't think is this visible or not. So yeah, the cup has significantly enlarged as compared to the whole disc. So basically the net effect is the thin neuroretinal rim, which actually carries the retinal nerve fibers. So that is very very thin. So that is one big effect of raised IOP or changes of the fundus in glaucoma. Now the localized defect can be seen here. The cup is not completely circular, but here instead it is like extending asymmetrically to one thing. So basically localized thinning or notching of the neuroretinal rim, commonly inferiorly or superiorly can also be seen. Now the asymmetry of the disc size in the two eyes, these are also the characteristics finding. So basically we are just simply observing the various characteristic signs found in glaucoma. So like asymmetry in both the eyes, like in the blood vessels and such. Now let's see the bayoneting signs. So this is an interesting sign. Basically the here blood vessels look like they are in 90 degrees, or sometimes can be said as they are broken. Like, so fundus photograph has shown that firstly the cup is to disc ratio is increased. Now this patient is glaucoma suspect. Now then we see the bearing of the circumlinear vessels, and where basically the curvilinear vessels parallel to the margin of the cup, which was previously hidden in the substance of the neural tissue, they are like now visible in this image. Now the important sign is the lamellar dot sign. Here if we enlarge, we can see there are several dot signs in the inside the optic cup, and also there is an hemorrhage present, which looks like a broken splinter. So that's important sign. And the nerve fiber layer defect is also visible here, where the early changes of the nerve fiber layer which are in the arcuate area meaning the temporal side of the visual field, temporal side of the retinal layer. With slit lamp biomicroscopy can be easily seen, and with slit lamp we need a plus 90 diopter lens to zoom in to see the whole fundus area. Okay, so parapapillary atrophy looks like this actually. Now the visual fields, basically this is the normal visual fields. The blind spot is in the left side, meaning the blind spot is actually in any patient is on the temporal side. So here this is actually the image of the left eye, so that's an important concept. So left eye, here basically the horizontal raphe, the central fixation point, this is the normal visual field. Okay, now in perimetry the visual field, basically the typical glaucoma visual field is described as visual field basically being the area of vision in a sea of darkness, like a tiny area of vision in a sea of darkness, that is typically described by the patient. Now here, what is the scotoma? It's an area of decreased retinal sensitivity within the visual field, which can either be relative or absolute. Now the scotoma does not mean that the area is fully black, like insensitive, but the scotoma here means that it is the decreased sensitivity of retina. Now the threshold, basically the dimmest stimulus which can perceived by the patient in 50 times, and I don't know why it is written here 50 times, but isopter is an important concept. So this is basically a line, the line of the visual field connecting the points in the same threshold, meaning basically the area like is the line of all the points of the visual field where the retina has the same amount of sensitivity. Like we have seen in this image. So here basically we will see in the further images that the lines are basically in oval in shape and given a specific degree value like 10 degrees from the central fixation point. Now the basically any point on whole of the isoptal line has the same visual sensitivity. That is the actually main concept here. So yeah, so about perimetry, that isopter is basically that line, and we have to see actually static and kinetic perimetry, but most commonly static perimetry is done. So yeah, so the visual field abnormalities are very interesting here. Basically the visual field anomaly means that there are two visual fields, like the central and the peripheral. So central visual field is basically from the point of fixation to 30 degrees in area. So this area is known as typically the central visual field. So basically like kind of here, this part is around 30 degrees in isopter value. That is the central, and beyond that the 30 to 70, like the superior field I think extends to 50 degrees, nasally 60 degrees, inferiorly 80 degrees, and the most amount is 90 degree, I think that is temporal, right? So the visual field anomaly here, the 30 degrees centrally is commonly evaluated. Now the relative paracentral scotoma, here basically the scotoma developing beyond the central region basically. So relative paracentral scotoma in same isopter of blind spot above or below the horizontal midline is the earliest changes of glaucoma. So this is an important thing. The next image is actually basically summary of all types of scotomas seen in glaucoma. So this is an interesting topic. And also, by the way, those of you who are watching right now, so this PDF, this PowerPoint presentation will be sent to the uh, WhatsApp group only. Sorry. So the main types of scotoma seen are Jerem scotoma, paracentral scotoma. Jerem scotoma means the superior kind of arcuate scotoma, and paracentral scotoma is here, which is just outside the central visual field. And then blind spot is the physiological blind spot. Then the centrocecal scotoma, central scotoma, and nasal step. Now the next thing is this is an important thing, which is bearing of blind spot. The bearing of blind spot means that the exclusion of the blind spot from the central field due to inward curve of the outer boundary of the 30-degree central field. Like the central field normally is or should be circular or oval in nature, but here the central field is twisted and it's asymmetric, so that the blind spot where the optic nerve, basically the optic disc, exits the eye, that is the not sensitive part of the retina, so that part is excluded from the central visual fields. Like the central field can be shown here only, it is excluded, so it's also known as bearing of blind spot. Here it's basically generalized depression can also be seen. Now here's another example of a scotoma, which is known as sedal scotoma. Now this is the arcuate or Jerem scotoma, not the B here is silent. And this is an biarcuate scotoma example, where the scotoma is present on upward and the superior and the inferior visual field. Now the next thing is Rene nasal step, where the nasal step can be seen on the temporal side. So basically this is the optic disc where there is the Jerem double arcuate scotoma and a nasal step where a vertically downwards scotoma type of thing is seen in the temporal, and this is the papillo like horizontal raphe, that is the extension of the papillomacular bundles. So from there the scotoma is seen downwards. Now these are the main things that we have to see, that are the tube vision. Okay, so just 1 second, let me check this. Okay, just 1 second. So yeah, let's continue. We are live again, I think. Yep. So yeah, the tube vision, so basically so overall we can see, just simply thinking about the concept, that is the scotoma develops from the side of the central vision, and it forms an arc. Then the arc actually covers both downwards, so the vision becomes tubular. We have only the central tunnel vision type of thing. Then from the outside of the thing, basically since the arcuate fibers are more commonly affected, the vision actually condenses downwards and we gradually lose the vision from outside to inside. So tube vision is an important symptom. Actually these symptoms are the progress, show directly the progression of the progression of the glaucoma, actually, because again and again I am trying to implement this point, that glaucoma is a progressive progressive irreversible visual loss of vision. So that's a important aspect of glaucoma. Okay, now let's see the temporal island, where basically the glaucoma can also be described as a tiny area of vision in a sea of darkness. Darkness in the later stages actually is very more in amount than the central area. So basically here and temporal island can also be seen in some cases. So very simply, the classification of glaucoma is basically congenital and acquired. And acquired may be primary, like with no apparent cause, and secondary, like after some cause or some secondary to basically কোনো injury or মানে মানে injury or any other associated disease. So basically classification of this glaucoma can be firstly childhood or congenital, which can also be primary and secondary. Now adult glaucomas are basically primary, which means the most important for actually our syllabus actually is the primary open angle glaucoma and primary close angle glaucoma. Secondary is basically open angle or narrow angle. Okay, so here is the very important picture. So the picture here shows, okay, just let me change this. So yeah, so the secondary open versus closure. So what actually means the open and closure glaucoma? Open means the iridocorneal angle, mane iris and cornea. So this angle has to be open. This image is actually not that accurate because the angle in concern here is the iridocorneal. So the actually aqueous humor is originated from the ciliary body. It comes from the ciliary body out from behind the iris. It comes into the anterior chamber, and out of the anterior chamber it goes through the two pathways. One most commonly the trabecular meshwork, and another via the uveoscleral outflow. So here the main angle in concern here is the iridocorneal angle, right? So iridocorneal, here the angle is obviously open. Open means the gateway of the exit or the drainage of the IOP, like the aqueous humor, is open. Now here the angle is actually can be clearly visualized. The iridocorneal angle is so near or so like closed. So basically the any aqueous humor where it generates from the ciliary body, it goes into the anterior chamber, but it cannot exit through the trabecular meshwork or the uveoscleral outflow. So basically to measure or to check that open or angle, iridocorneal angle is open or not, we have a very important diagnostic test, that is gonioscopy. So gonioscopy, what is actually gonioscopy? Gonioscopy is the test or visual examination where we make the patient sit in the slit lamp in front of the slit lamp biomicroscope, and we use a specialized device or specialized lens, which basically does nothing but it matches the refractive index of the cornea. So now why that is important right now, because we know from a physics principle that the light in any change in media of the refractive index, the light, if it strikes at an refractive index boundary, like medium to media boundary, if it is more than critical angle of the media, then it gets totally reflected back into the media. So like the light coming from the from the iris, light coming from the peripheral of the iris, when it comes to the cornea, like when here the light when comes to the cornea hits the cornea ear junction, now it is always the critical angle, I think it's 46 degrees. So if it is more than 46 degree, and due to the curvature of the cornea like this, it actually gets totally reflected back inside the cornea. So normally we cannot see the light that comes from the outer edges of the iris. So in order to see that, we have to place the basically some we have to obliterate this air cornea barrier. So how to do that? Basically, simply we have to place basically gonioscope. Gonioscope is this instrument which is actually has similar refractive indexes to indices as that of the cornea. Now when we match that refractive index, we further use a viscoelastic gel to obliterate this air gap. Now what happens that these two media has nearly the same reflective index. Now the light that comes from the outside edges of the cornea can simply go in a straight line, and here is a mirror which reflects this light towards the examiner's view. So basically what's happening that the light here can does not undergo the total internal reflection, but instead can be seen from the mirror. So the common examples are basically three mirrored gold man. Here also the Goldman, we have learned that Goldman applanation tonometry is one thing, and here also Goldman has invented a gonioscope, which is three. This is an indirect gonioscope because the light is reflected from the mirror which is already present inside the gonioscope. Now if this light actually passes directly in front of the examiner's eye, directly in front in a straight line, so that will be direct gonioscope, which is not commonly used. Here the three mirror gonioscope commonly used is basically Goldman's gonioscope. So yeah, let's see from basically the posterior to anterior the structures observed here. This is the important thing, which is basically ciliary body, scleral spur, trabecular meshwork, and pigmented and non-pigmented, basically these two, and the Schwalbe's line, right? So this is the top view of the gonioscope. We can clearly see that there is three mirrors present here. So this is the actual Goldman gonioscope probe, right? Okay, so I think I can give you a simple mnemonic here, which is STSC. Okay, now STSC like scleral spur, trabecular meshwork, Schwalbe line, and ciliary body by ciliary band. Okay, so here is the very simply put structure, which is basically the Schwalbe line, non-pigmented trabecular meshwork, pigmented trabecular meshwork. ठीक है, these two are trabecular meshwork, then the scleral spur and ciliary body band. ঠিক আছে, তাহলে posterior to anterior, তাহলে ciliary body band, scleral spur, trabecular meshwork, and Schwalbe line. Like we have seen here, from posterior to anterior, these four are very important structures. Now the type of glaucoma we are going to study is basically POAG. So what's the full form? Basically it's the primary. Primary means that we don't have any associated cause why this glaucoma is happening, and this glaucoma has a characteristic feature of open angle. Open angle meaning the iridocorneal angle is not like completely closed, so it is open, meaning around it's 40 or more degree in value. Now the common type of primary glaucoma in white and black people, so these are about 50% of all primary glaucoma in Asian people. So this is the rough epidemiology, which is not that commonly required right now. Now it's an adult onset glaucoma. Now right, the glaucoma here, if we use the term adult, it does not mean that it's above 18 years of age. That is the legal term of the adult. Here adult glaucomas mean that glaucomas occurring after 40 years of age. So that is a very important thing. So like we do not call the glaucomas occurring in patient with age more than 18 and below 40. We do not call them as adult glaucomas, but we call them as juvenile glaucomas. So that's an important thing. We are going to understand all the congenital glaucoma and the juvenile glaucoma in the later slides. So let's study the most like important among common thing, which is the primary open angle glaucoma. Is adult onset. It is actually bilateral and maybe asymmetric. So here this is an important features to note, which is also it's familial. So any glaucoma patient has to be screened for their immediate blood relations, and common association is diabetes and high negative power, which is myopia. So these two are important things. So the symptoms of POAG is basically asymptomatic at first. But the vague symptoms like headache, eye ache, decreased contrast in sensitivity in the dark, these can also be found here. Now the frequent changes are of presbyopic glasses. Like I already mentioned that the a patient's age here is adult, meaning he or she is more than 40 years of age. So more than 40 years of age is the also typical time period of the development of presbyopia, which is basically both near and far, like loss of accommodative changes. So the patient already has presbyopic glasses. Now if he requires frequent changes of that glasses, so that can also be a symptom of primary open angle glaucoma. So now, like, let's see a very simple kind of image. So how the primary open angle glaucoma symptoms develop, which is initially it's painless and has like no initial symptom, like the patient can see like normal vision in the earlier stages. Like example is this. Now if untreated, the peripheral side of the vision is lost slowly. So basically the patient has like encroaching kind of field of view, where the field of view gradually like decreases from the peripheral, like in the temporal side of the hemisphere. So gradual narrowing and tubular or tunnel visions, ঠিক আছে, the defective side মানে the objects cannot be properly seen, but like around or beyond the central vision. And eventually, if completely untreated, because glaucoma visual field changes is irreversible, so this is a very important thing, that the glaucoma patient need to be diagnosed very early, right? So if the glaucoma patients are not detected early, because we cannot reverse the visual changes already, all the damages that already happened in the glaucoma patient, we cannot change that. But we can do is detect the glaucoma changes early. The glaucoma meaning is actually that, again, that progressive optic disc changes, and number two, progressive irreversible visual field changes. So if we detect these two early, we can actually treat the patient to stop this progression, further progression of like patient where the normal vision, if already the visual field is damaged, the progression into complete loss of vision can be stopped, right? So the signs of POAG, where patient can have increased IOP, like increased 21 millimeter mercury in intraocular pressure, but sometimes the IOP can also be less than, consistently less than 21, within normal range, which is 10 to 21 millimeter, right? So that can be known as the normal tension glaucoma. This is a very important thing, that glaucoma never like always means that increased IOP. So increased IOP is a risk factor for glaucoma, but increased IOP does not mean glaucoma. Increased, if that is independently present in a patient, that increased IOP is actually termed as ocular hypertension. So increased IOP does not mean glaucoma. So that's an important thing. This is normal tension glaucoma, and subject who have the IOP persistently more than 21 millimeter mercury has no other change. That, yes, exactly this I am trying to point out, that just the presence of IOP increase with no other additional changes of glaucoma, which are basically optic field changes, irreversible loss of vision, and optic disc changes, like on ophthalmoscopy. If these two changes are not seen, then the then the patient is actually suffering from not glaucoma but ocular hypertension, right? And it is an increased risk of further development of open angle glaucoma in the later stages, but it is not glaucoma right away, right? And yes, the very important thing is the IOP actually varies due to many factors, because like if you drink more water, so more fluid is in the system, so ciliary body will filter more IOP. So basically that occurs, and IOP is IOP, like intraocular pressure, is actually dependent on many other factors, where the another important factor to note is basically the time of the day. So normally the IOP actually decreases in the evening and rises in the morning. This is the normal change of the IOP. Now the variation in IOP should be, if within a day, should be less than 5 millimeter mercury. Say suppose the patient has 15 millimeter mercury in the evening, and the next morning he has say suppose 20 millimeter mercury. So within 5 millimeter mercury change of pressure of IOP is normal, but if this change appears huge, like more than 8 or more than 8, 8 millimeter mercury or more than 8, then the change is suspectly or strongly suggestive of glaucoma. And also if the diurnal change is actually reversed or biphasic, like it increases during the day, decreases and again increases during the evening, or if it just increases during the evening and later during the decreases during the morning, so that is actually the ulto of the normal IOP changes, so that is also suggestive of glaucoma, right? So asymmetry of IOP in two eyes can also be suggested if the IOP values are more than 5 millimeter mercury. Okay, so let me just so next we are studying the science and basically characteristic glaucomatous changes in the optic disc, right? Acha. So what are the characteristic optic disc changes? Where the first thing we saw in the previous slides, but the characteristic changes are basically the increase in the cup ratio. Cup is to disc ratio should be more than 0.7 to actually diagnose or confirm case of glaucoma. Now the characteristic visual field changes, these two are should actually be present independently or with increased IOPs to confirm that this patient has glaucoma. So and open and the angle of anterior chamber should be open to actually diagnose this case as a case of glaucoma, but primary open angle glaucoma. Primary meaning this has no associated secondary causes like diabetes, say, or any other disease. So, open angle here means the anterior chamber angle where the iridocorneal angle is open, or basically more than 30, it's around 30 to 40 degrees. So basically the trabecular meshwork and all the drainage systems are open and there are no associated abnormalities, but there are characteristic signs like optic disc changes and visual field changes. So if these two along with the angle of open anterior chamber is open, so we term that as POAG, POAG. So that is primary open angle glaucoma. And now the newer diagnostic tools we have which actually lets us diagnose the cases are optical coherence tomography, and we can also diagnose the POAG case by laser polarimetry, scanning laser polarimetry, and the disc assessment can be done by scanning laser ophthalmoscopy by Heidelberg retinal tomography. So these three are just for knowledge purpose. Actually if you are interested, you can go into Google and go into a deeper dive, but I don't think these are necessary right now, just because just for the purpose of preparation of the exam. So these three are just a factual knowledge, right? So treatment of POAG, here the treatment part is very, very important, and actually I want to discuss the various treatment options. So we need to study the treatment of glaucoma in respect to not only a specific type of glaucoma which is POAG. POAG treatment is specific to POAG, but overall we should know the various treatment options. So main treatment, any disease has medical treatment or surgical treatment. Now medical treatment is basically what's the use of drugs. So various anti-glaucoma drugs are present, right? So we first need to learn about the anti-glaucoma drugs in a general way. Then we need to apply that knowledge in specific cases like that of here in POAG. So I am going to actually do that right now. Right now I'm going to shift to another presentation. So let's see this. No, this is actually the investigation part. Just a second, I need to quickly. Yes, so anti-glaucoma drugs. This is currently opening right now. Yes, so I have found a PPT by Dr. Ankita Mahapatra of Department of Ophthalmology, VSSIMSAR, Burla. So she has prepared this amazing slide where there are various overall we can learn the anti-glaucoma drugs. There are various classes, their mechanism of actions, and on which purpose or which cases we can actually use these anti-glaucoma drugs. So basically the aim of the treatment, I don't, is it visible? The people who are watching right now, hello sir, commentator Kaku says he's studying ComMed. Okay, so hello commentator Kaku. So yeah, so the aim of glaucoma treatment here, yes, let's see, the is to basically use glaucoma drugs or ultimately to decrease the IOP, intraocular pressure, right? So the mechanism basically are reducing the aqueous production of the ciliary body, or promoting more aqueous outflow through the trabecular meshwork or through the uveoscleral outflow. These two are the main outflow. So either basically we have to decrease the production or increase the outflow. So increase the outflow either through the trabecular meshwork and the uveoscleral pathway, right? So the various drugs we see are basically generally classified here. So this slide is actually very helpful to know, because the drugs which increase the trabecular outflow versus these are miotics, epinephrine, dipiveprin and bimatoprost. Now the drugs which increase the uveoscleral outflow are prostaglandin like latanoprost, and alpha agonists like brimonidine, epinephrine is also why is epinephrine alpha agonist? Brimonidine, apraclonidine actually are the two main alpha agonists, right? Now, and the decreased aqueous outflow or decreased aqueous production, the term here is not correctly used right now. So the decreased aqueous production are by this is carbonic anhydrase inhibitors, which are basically acetazolamide and dorzolamide. Alpha agonists can also be used through this mechanism, which is epinephrine, dipiveprin, clonidine, brimonidine, and beta blockers like timolol, betaxolol. So we are going to study these in detail. So if we have this knowledge of the anti-glaucoma drugs in a general pattern or in a overview manner, we can apply this knowledge to the specific glaucoma types that we are going to study in the later pathways, right? In the later slides. So basically the next we are studying the parasympathetic mimetics or cholinergics. So here the mechanism of action is actually very simple. So these are contraction of the iris sphincter, which constricts the pupil. Now this actually moves the iris away from the trabecular meshwork. So when the trabecular meshwork is like away, the contraction causes the increased outflow, right? So that is the main actual function. So this is very simply explained in this this now flowchart. We are going to see the parasympathetic mimetics can either be directly acting like pilocarpine, indirectly acting like cholinesterase inhibitors, like if reversible then physostigmine, irreversible we can see ethiopiate iodide, then না বাকিগুলো লাগবে না, শুধু thiopate iodide, right? So we have actually learned about this in pharmacology, right? And the dual action like carbachol and carbachol, I think carbachol, and there was also another drug like carbachol beta something, I think. Okay, so never mind. So basically the parasympathetic mimetics are directly acting, indirectly acting and dual action, right? So simply said, these three are the important thing. And the carbachol eye drops, these are all topical eye drops obviously. So these are present, you can clearly see the coli. So in these names the drugs are available in the market. Now the pilocarpine here, the overall we have to just study, we don't need to study in such depth that we actually enter pharmacology and skip the ophthalmology part. So the overall thing is the pilocarpine indications is patient with IOP having persistently occludable angle despite iridotomy. So the angle can be opened by the contraction of the iris, which actually moves the iris away from the trabecular meshwork and opens the iridocorneal angle so that the aqueous outflow can increase. So that is the indication. And contraindication is uveitic glaucoma, which I have no clue what that means. So I am just going to skip that part right now. And yeah, So the available preparation, I don't, yeah, OcuSearch eye drop is most commonly used. OcuSearch meaning basically where the uh, a thing is with the drug is placed under in the palpebral conjunctivus. So here the drug is constantly কি বলে constantly ejected from the OcuSearch, ঠিক আছে, and these and pilocarpine gel also can be used, right? And side effects are ocular like posterior synecdoche, keratitis, myopia, systemic like sweating, and then bronchospasm. So yeah, so if it causes bronchospasm, we absolutely cannot give in asthma patients, so that is absolute contraindication. Now the carbachol is basically an alternative to pilocarpine, because we see the carbachol was the key mixed, right, mixed or dual action of parasympathetic mimetic, like directly and indirectly acting, right? So this is an alternative, so in alternative used in resistant or tolerant cases. Best as simple as that, right? Now sympathetic mimetics are the main second class of the drugs which we need to study, which are basically non-selective, selective, and uh, selective alpha 1 alpha 2 and selective alpha 2. So we, the pharma people commonly know of these names. Non-selective meaning the epinephrine, dipiveprin, right? Selective is apraclonidine, and selective alpha 2 is brimonidine. So these three are important, and this is the very 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 important graph or image of the receptors. So basically these are the carbonic anhydrase receptors, beta 2 receptors, alpha 1 receptors in the ciliary blood vessels, and in the ciliary body epithelium there are alpha 2 receptors, right? So selective alpha 2 receptor meaning agonist meaning ki je brimonidine, and selective alpha 1 alpha 2 only alpha 1 alpha 2 adrenergic receptors. These are basically the apraclonidine, and the non-selective like epinephrine meaning adrenaline, right? Adrenaline actually acts on alpha 1 alpha 2 beta 2, all the receptors. And so since this is non-selective, so it has systemic side effects also, so we try to use the more selective A1s, right? And basically the simple concept on epinephrine, so these are available in obviously 0.5, 1%, 2% eye drops, and the action starts within the first hour and lasts up to 12 to 24 hours, right? So this is an important thing. And epinephrine is the non-selective one. Dipiveprin, propine or dipiveprin, epinephrine, such a confusing term. So simply dipiveprin is a prodrug which is converted into epinephrine when after it is absorbed in the eye. So it is more lipophilic than epinephrine, so basically the penetration is 17 times more. So this is a very efficacious drug. And next we see clonidine or apraclonidine. These both are selective alpha 1 alpha 2 agonists. So these actually decrease the aqueous production, because we have seen that alpha 1 alpha 2 receptors are present where? In the ciliary body epithelium, right? Now in the ciliary body epithelium, these actually decreases the aqueous humor production. So 0.6% to 0.1 to 5%. Side effects can be conjunctival blanching, sedation, dry mouth, right? And apraclonidine also decreases aqueous humor production, and this also has an additional effect of increased or improvement in trabecular outflow, right? And these are the following uses of apraclonidine. These are to be understood when we go into the later chapters of say laser trabeculoplasty, right? And side effects are allergic reaction, and then blah blah blah. And brimonidine is the more selective alpha 2 action, where there is less chance of tachyphylaxis and ocular allergic reaction, and IOP reduction is very very efficacious, right? So these are done, and now we finally reach the adrenergic antagonist, which are the beta blockers. So beta blockers are of two types, obviously: non-selective beta 1 beta 2 and selective beta 1. So non-selective beta 1 beta 2 basically are timolol, levobinol, cartelol, metipranolol. So these are kind of new terms, but simply timolol is the non-selective and betaxolol are the beta 1 selective, right? And the mechanism of action here is the same diagram, where basically the beta blockers act on the beta 2 receptors, right? And beta receptors, and these block the beta receptor in the ciliary process and decrease the CAMP production and decrease rate of aqueous production by 20 to 50%. So this is very, very efficacious, and beta blockers are less effective during sleep, so that's an important point to know. And the drugs are obviously timolol maleate, betaxolol, cartellol, and cartellol has actually the least effect on lipid profile, so that's an additional knowledge, not just required right now. Just let me check the stream once a bit. I hope everything is okay right now. The drugs are obviously timolol, maleate, betaxolol. Yeah. So dosing, the first thing in the morning is preferred to blunt an early morning pressure rise. So we have to actually prevent the early morning pressure rise very much. And beta blockers can be given in addition to miotics and adrenergic agonists and carbonic anhydrase inhibitors, CAIs, and prostaglandin analogs. Prostaglandin analogs like latanoprost, bibartoprost, travoprost, right? Sorry. So beta blockers are very good synergistic effect with combined miotics, and thus are often used in combination with patients with POAG, primary open angle glaucoma, right? Timolol and latanoprost combination can also be used in additional to IOP reduction of 13 to 37%, which is completely irrelevant right now. Okay, so the side effect part is in ocular side effects like local anesthesia, dry eye, conjunctival hyphema, hyperemia, like increased blood flow, and systemic side effects like bronchospasm and bradycardia, decreased cardiac output, hypotension, depression, impotence, altered lipid profile. So these are important. And the contraindication part, the contraindications are basically the bronchial asthma. This is a very, very important part, because in bronchial asthma, if you give beta blockers will actually cause bronchospasm, and the aggravated condition of the bronchial asthma will occur. So that, and emphysema, and any COPD, any respiratory problems, we cannot give beta blockers at all. So this is a very, very important point actually. COPD, heart block, congestive heart failure, cardiomyopathy are known drug allergies, right? And reduce glucose tolerance. So that can also be a part of the contraindications, right? So right, this is a important pharmacological concept, that hypoglycemic signs are actually masked by beta blockers, right? So in diabetics we cannot give, right? We can it can give us false results. And the next part, which is important, which is prostaglandin analogs. So let me just quickly see how much time we have. Yeah, so it's 50 minutes of discussion already, so I will try to wrap this session quickly here, and after the break we are going to study about the rest of the thing, which are primary open angle glaucoma, closed angle glaucoma, congenital glaucoma, and secondary glaucoma. These 4 topics are the main topics we are going to start after the break, which is basically just on 7:10 p.m. So let's start. So the prostaglandin analogs, the mechanism of action is very simple. Stimulates prostaglandin receptor in ciliary muscles and release of matrix metalloprotease, and degrade the extracellular matrix between the ciliary muscle bundles, and reduction of the hydraulic resistance to uveoscleral outflow. Like prostaglandin actually functions by decreasing the increasing the uveoscleral outflow, right? That is the main point. So what are the drugs? Latano, bimato, and travo. So these 3, latano, bimato, travo, and unoprostone, these 4. So these 3 are in yellow, these 3 are the main prostaglandin analogs, which function in this way. Ciliary metallic protease, decrease the extracellular increase the ultimately uveoscleral flow, and the unoprostone actually has an additional function by increasing the retinal blood flow. So it actually helps in decreasing the aqueous humor by uh, increasing the drainage of the retinal blood, ঠিক আছে, and the side effects are basically similar. And here what the important thing is, contraindication is inflammation can, here we cannot give, and the advantage is once daily dosing, so a lack of cardiopulmonary side effect which is found in the beta blockers, and other we can give to in addition to other anti-glaucoma medications. Now let's see the carbonic anhydrase inhibitors, which are the most important and commonly used systemic anti-glaucoma drugs, which are function in this mechanism, inhibit the carbonic anhydrase in ciliary process. Ciliary process, the carbonic anhydrase enzyme is inhibited, which decreases the aqueous humor production. Ultimately, the IOP decreases. So the drugs, this is the very important classification of the anti-glaucoma drugs, which are carbonic anhydrase, which can either be systemic or topical. In systemic, we see acetazolamide, which is very commonly used drug. Acetazolamide, methazolamide, dichlorphenamide, and ethoxylamide. And topical are dorzolamide, brinzolamide, and lutaxamide, right? So these 7 drugs are basically the main carbonic anhydrase inhibitors. So the commonly used drug is acetazolamide. So acetazolamide is reduces IOP by 30 to 40%, and it's an oral drug. Remember, it is not a drug, topically used drug. So very high IOP in acute angle closure can be controlled by acetazolamide, right? Now the doses is 250 milligrams tablet 6 hourly, and rest of the thing are not required, and the side effects are obviously required, which is side effects can be hypokalemia is an important side effect, metabolic acidosis is an important side effect, renal stone is an important side effect, and blood dyscrasia is also an important side effect. Acetazolamides are, remember, not metabolized, excreted in urine, so can be given in hepatic failure because the hepatic metabolism is not present, and methazolamide is metabolized by liver, so methazolamide also has a decreased risk of systemic adverse effects, so that's an important thing. And dorzolamide and brinzolamide, these are the topical preparations of the carbonic anhydrase inhibitor, where the dorzolamide basically is 2% and brinzolamide is 1%. Here the side effects are punctate keratitis, bitter taste, allergic reaction, etc. And hyperosmotics, these are the next drug classification. Basically, hyperosmotics meaning the IV mannitol, that is very important. IV, intravenous mannitol, and oral glycerol, right? So mechanism of action basically increase the blood osmolarity, increase করছে the osmotic gradient between the blood and the vitreous has increased, right? So blood will now extract the more vitreous water, and so drawing of the water from the vitreous cavity actually decreases the IOP. So these two can be used, which is mannitol and glycerol. Mannitol meaning 20% and glycerol is concentrated 50% nearly, and it precipitates hyperglycemia and ketoacidosis in diabetes. So glycerol cannot be used. There's a biochemical association actually here. Glycerol metabolism pathway actually is defective in diabetic patients, so glycerol causes hyperglycemia, right? So that is a contraindication. And side effects of mannitol are basically IOP can be reboundly increase in aqueous flare, headache, mental confusion. So hyperosmotics are contraindicated in patients of renal failure or dialysis. That is an important thing. And hyperosmotics are not commonly given due to these many abnormal side effects, right? And this is a fixed combination of eye drops which are available, but these are not required at this level right now. And yeah, so now the more specific anti-glaucoma treatment here are written in these 2 slides. So these 2 slides we are going to again revise in the next session. So now let's go into the first break and let's join the session in the next time. So I'm just going to try and so let's take a quick break right now, and let's take a quick break. So yeah, let's meet after the break. Hello, hello, hello. Hello, hello. So we are back after the break. Okay, just let me recheck the stream quality. Am I audible? I think. Hello, hello. Am I audible? So, if I am audible, just put please someone who is watching right now, write in the stream chat if I am audible. So the next thing we are going to start right now, that is the treatment part of the POAG, primary open angle glaucoma, from where we left. So yeah, the simple part is, just let me. So yeah, the treatment part of the primary open angle glaucoma is reducing the IOP. Is the main effective therapy in treating. So the treatment is mainly primarily medical treatment. Laser trabeculoplasty can also be done. Surgical treatment can also be done, and so that is the overview of the treatment part. Uh, so yeah, so the medical treatment is to reduce the IOP with anti-glaucoma drugs. Now, anti-glaucoma drugs are basically, we already studied the prostaglandin analogs, latanoprost, bimatoprost, travoprost, then beta-adrenergic agonist, which is non-selective both beta 1, beta 2, timolol, beta blockers, beta 1 selective beta-xolol, right? And the next part are sympathetomimetic, which are non-selective like dipiveprin, which is the precursor of the epinephrine, which is 0.1%. Selective is alpha 2 agonist, which is approgonodine, brimodidine, right? And brimodidine is more selective. This we already studied in the earlier slides, right? And carbonic anhydrase inhibitors like systemic, obviously acetazolamide, which is very common, and topical are dorzolamide and brinzolamide, right? And parasympathetic mimetic, which is pilocarpine eye drops. So we already studied the mechanism of parasympathetic mimetic are basically they contract the iris, which the contraction of the iris causes iris to move away from the cornea. So if the iris contracts, it moves away from the cornea, and here this angle is actually now open. So it actually increases the trabecular outflow, right? So that is the mechanism of the sympathetic mimetic, pilocarpine eye drop, 2%. Now the hyperosmotic agents we already studied, like oral glycerol 50%, IV mannitol can also be given, but we actually studied that these two have very higher side effects than the actual effects medical. Now medical therapy are basically primarily monotherapy with topical prostaglandin analog like latanoprost, bimato, travoprost, and or beta blocker, and like monotherapy with primary prostaglandin or beta blocker. And if ineffective this monotherapy, then it is combined with the topical carbonic anhydrase inhibitor like dorzolamide, or topical alpha agonist like brimonidine. So this is an important thing. Some experimental neuroprotective agents are also used, and success is evaluated by obviously the reduction of the IOP value and stabilization of the disc changes and visual field changes. Basically, the three main parameters of glaucoma, right? Now the laser therapy, here argon laser trabeculoplasty can be done, or selective laser trabeculoplasty, and to supplement the inadequate response with medical therapy. Like medical therapy is given, but these effects were inadequate and not up to the mark, because it couldn't decrease the IOP of the patient. Now we also use the laser therapy. Just a second. So yeah, laser therapy can also be used in response to medical therapy. Now usually this laser therapy is temporary, because the low intensity multiple burn at the trabecular meshwork to produce traction and opening up of anterior trabecular pores, right? So that is the important thing. Surgical therapy here, the filtration surgery like trabeculectomy, like we actually cut a part of the trabecular meshwork out. So that's the filtration surgery. Now glaucoma valve implant like Ahmed valve can also be done. Indications of surgery are obviously when drug therapy fails to control the IOP, and if patient cannot afford the cost and patient cannot tolerate the side effects of the drug and poor compliance, so we have to give all those cases the surgical therapy. So let me just check my voice is okay. Yes, my voice is working perfectly. So now the second type of the adult glaucoma meaning more than 40 years, which is primary angle closure glaucoma, right? So PACG, the peripheral iris move to block the access of the trabecular meshwork, the peripheral iris. So if this is the cornea and this is the peripheral iris, it comes in front and blocks the opening of the trabecular meshwork, right? So the commonly seen among the Asians, about 50% of these are primary glaucomas, and Inuits. Predisposing factors are obviously female. Now these are important things. These are risk factors of the angle closure glaucoma, which is females, small eye, small corneal diameter, relative anterior posterior of lens anterior position of the lens iris diaphragm, then relative pupillary block, then increased lens size in older age, and at twilight or in emotional stress this angle closure can also occur. So let's see what's the physiological pupillary block. So basically here the block means the iris has large arc of contact with the anterior surface of the lens. The anterior surface of the lens and iris membrane actually is in contact with each other. Now if this contact persists, this pupil is like blocked, right? Pupil is not moving, and this immobile pupil actually results in the increase of buildup of aqueous humor behind the iris, right? Now this occurs in resistance from the aqueous flow from the posterior to the anterior chamber and relative pupillary block. Now the pupil actually dilates in these cases, and the peripheral iris becomes more flaccid and pushed anteriorly. If the peripheral iris actually is pushed anteriorly, then the trabecular meshwork, the main part where it is present in front of the peripheral iris, that gets blocked in on on the effect of the due to the effect of the pupillary block, and the iris lies against the trabecular meshwork, which impede the aqueous humor drainage, and increase in IOP occurs, right? So the clinical features generally are bilateral in both eyes symmetrically, and depends on the stage of the disease. Now the stages are, this is the very important thing, the stages of primary angle closure glaucoma. The stages previously had been classified into 5 stages. Number 1, incipient stage, stage of constant instability, acute angle closure glaucoma, chronic angle closure glaucoma, and lastly the absolute glaucoma. Now these are the important 5 stages previously. Nowadays, now the ISGEO organization has given primary angle closure suspect, right? And then the PSC and the primary angle closure glaucoma, PSCG, is the next step. Primary angle closure glaucoma is the next step. Then we see the acute primary angle closure glaucoma, which is a very acute medical condition, right? So basically the ISGEO has given us 3 stages, which is PSC, PSCG, and APAC, right? Now we see the next important slide, which is primary angle closure suspect. So basically here the non-visibility of the PTM in 3 or more quadrants, and no pass and normal IOP, normal optic disc and field. So these are the primary angle closure suspect. Now PAC, primary angle closure. So first is actually suspect angle closure glaucoma, and acute primary angle closure glaucoma. So these are the 4 stages of modern stages of the AP কি বলে angle closer glaucoma, right? Now here the angle closer, here the non-visibility of the posterior trabecular meshwork in 3 or more quadrants, and raised IOP and normal optic disc changes. Like we do not term the full glaucoma here, but we give the term primary angle closure. The angle closure has happened here, and closure may be intermittent during reduced illumination, and patient may experience colored halo around the lights. So this is an important thing. Next we see the primary angle closure glaucoma, right? So primary angle closure glaucoma, PSC, primary angle closure plus glaucomatous damage like optic disc and visual field. And now finally the acute congestive stage, like, or acute primary angle closure glaucoma. So this is also was termed as acute congestive attack in PSEG. Symptoms are ocular and periocular pain, which is very severe and unilateral present, rarely bilateral. Severe dimness of vision may be HM plus, hand movement plus close to face, and systemic features like nausea, vomiting, abdominal pain can also be present. Similar attacks in any past may be there, right? Now next we see that the signs of the acute primary angle closure. So the commonest sign we see here is the corneal edema. Now due to edema of the cornea, the vision loss is severe. Here the IOP is very high, very high, 60 to 80 millimeter mercury high, like so high, and the circumcorneal congestion is present, and incisive hazy cornea, because the cornea has developed he's imbibed the water and became not transparent but translucent, and edema, and very shallow anterior chamber, like the front of the lens has come forward, and all the angle of the iris has iridocorneal angle has been blocked. So there is very shallow anterior chamber, and the areas of iris atrophy from the past attacks are present here. Now pupil is mid dilated and vertically oval, like in this shape, and non-responsive pupil, right? And lens may have anterior subcapsular opacity, glaucoma flecken, right? So differential diagnosis of acute IOP elevation, this is an important thing, where the lens induced angle closure can also these are the main factors or main diseases where the acute IOP elevation can be seen, which has lens induced glaucoma, malignant glaucoma, neovascular glaucoma, hypertensive uveitis, scleritis, pigment dispersion, etc. Right? Now the signs of the primary angle closure signs is basically the gonioscopic and fundus examination is not possible because there is corneal edema. Now the corneal edema can be decreased by hypertonic saline, like more sodium containing saline, and or glycerin drops, like glycerin drops can be act as a hyperosmotic agent, and anterior chamber angle is completely closed here, right? And disc may look hyperemic, increased blood vessels in the optic disc in the behind of the eye, in the retina, and swollen. And so the management part is the important part here. So the reduction of the IOP also, which has to be happened quickly, so by hyperosmolar agents like IV mannitol, right? Hyperosmolar agents like IV mannitol 20% or glycerol 50%, or tablet acetazolamide 500 mg stat, then 250 mg 4 times daily. Aqueous suppressants like beta blocker, beta agonist, blah blah blah. Then IOP decreases, topical pilocarpine 2% QID to constrict the pupil can be given to reduce inflammation by topical steroid. As soon as the cornea starts to clear, then we can give YAG laser peripheral iridotomy. So, and lastly, to constrict the pupil of the other eye too, we have to give the pilocarpine and do a prophylactic YAG laser peripheral iridotomy. That is very important. That is an important short note also, why we need to do peripheral iridotomy in the normal eye of the patient who have developed unilateral angle closure glaucoma. That is because there is a risk of development of the angle closure glaucoma in the other eye also, which is not which is normal right now, but it can develop that angle closure glaucoma, right? And PSC suspect management is what basically observation or laser iridotomy can be done prophylactically. But if significant cataract present, then obviously you have to manage the patient according to cataract. And the primary angle closure management here, the laser PI access the angle, medical treatment or trabeculectomy depending on the situation, and if significant cataract occurred, then cataract surgery has to be done. And primary angle closure glaucoma management, the laser iridotomy is done first here, because the angle is closed, so no amount of drugs are to be given, because drugs will not work here, right? If angle opens and IOP is controlled, then observe, just do observe. But if not, then same as primary open angle glaucoma, which is basically after the laser iridotomy, we have to basically undergo give the patient the medical management, right? And if significant cataract, cataract surgery has to be done. And now the important thing, which is basically the congenital glaucoma. So we finished two major, primary open angle glaucoma and primary angle closed glaucoma. Now we see the congenital glaucoma, which is basically the congenital glaucoma types are true congenital, infantile and juvenile. Now these three are considered under the congenital. I have to mention this again, that congenital glaucoma does not mean that the patient has to be just born, because the congenital glaucoma can occur up to 40 years, because congenital glaucoma can be either true congenital, secondly infantile glaucoma, like in infant up to the 1 years of age, and juvenile glaucoma also. Juvenile glaucoma meaning 18 years to less than 40 years. So these to up till 40 years glaucoma can be classified in under congenital glaucoma. So congenital development glaucoma in childhood, adolescence, congenital infantile up to 3 or 4 years. So eye is actually distensible, so progressively enlarges. So this is known as ophthalmos. This is an important actually short note in given quest actually. Now, if the glaucoma develops after 3 to 4 years, no enlargement of the eye, like development glaucoma, is basically the term, and occurs due to abnormal development of the trabecular meshwork, right? Now, clinical symptom features most commonly into congenital glaucoma in boys, and size of the eyeball is in increased, photophobia, watering, hazy cornea. So these are the clinical features, which is EUA, and corneal diameter if increased before the onset of 3 years. Like see here, the patient's cornea is so large in amount, and the white sclera is like very less visible. So corneal diameter has increased. Now enlargement is more than 12 millimeter in the first year is highly suspicious. So high IOP is also a very suspicious sign, and optic disc changes may be reversible if the IOP can be normalized early. So we have to prevent all the glaucomatous changes here, right? And the signs is ruptures of descemet membrane, double line, hypstria mostly horizontal, and edema of the whole cornea after hydrops, and scarring develops. Achha. Right. So the next part is the signs of the congenital glaucoma. The anterior chamber here is actually deep. So this is counterintuitive logic. Lens is backwardly shifted, iridodonesis, myopic shift. And so let's see the treatment part, which is primarily surgical meaning congenital glaucoma, we have to prevent the glaucomatous changes earlier, so we have to go for the surgical treatments. So medical to control the IOP till surgery is done. So goniotomy you have to done, and trabeculectomy, right? So combined trabeculectomy, goniotomy. Here the image is basically this. So we have to open the peripheral iris, and trabeculectomy is actually done to open the trabecular meshwork. Like here, this image can effectively demonstrate here because and trabeculectomy can be done and if bleb formation also occurs. So and glaucoma drainage by valve mechanism, we have to place a tube shunt in the glaucoma in the eye to prevent the development of the angle closer. So the secondary glaucoma, this is the next third important topic, which can be open angle or narrow angle. So open angle means that the glaucoma can either be, secondary meaning the glaucoma is due to any secondary causes, like secondary causes meaning steroid induced glaucoma. So secondary can be phacolytic glaucoma, thirdly can be pigmentary glaucoma, and pseudo exfoliation syndrome, right, traumatic glaucoma. Now the narrow angle can either be due to phacomorphic anterior subluxation of lens and neovascular glaucoma, like neovascular meaning মানে cancerous growth is present and epithelial downgrowth or malignant glaucoma. Now lens induced glaucoma meaning open angle phacolytic in hypermature Morganian cataract, phacoantigenic, previously phacoanaphylactic. Third is lens particle glaucoma. And under angle closer glaucoma, here the phacomorphic is intumescent cataract can also be lens induced glaucoma and by lens dislocation or subluxation. So and the third type of secondary glaucoma is basically phacolytic glaucoma. Phacolytic meaning immature or hypermature cataract due to cataract, the leakage of the lens protein through the leaky capsule. Now inflammatory reaction in the anterior chamber, drawing all the macrophages and phagocytosing the lens proteins, right, and pores of the trabecular meshwork get clogged by swollen macrophages, so that causes the glaucoma presentation. So the treatment here is either to control the inflammation because it is a primarily inflammatory condition, to reduce the IOP reduction can be done by medical means, and finally we have to remove the cause, which is the lens, so lens extraction can also be done. So the phacomorphic glaucoma here can be either due to intumescent cataract, like not mature, and causes are pupillary block, shallowing of anterior chamber and closing of the angle, and laser peripheral iridotomy. So I have a plan that after all this we are going to actually see and understand videos of the iridotomy and iridectomy, the glaucoma surgeries, right? So that will, I think, probably make this presentation much more interesting. And laser peripheral iridotomy to remove the pupillary block, and medical means to reduce the IOP, lens extraction can also be done. So with this we reach to the very end of our presentation, and now what I am going to do is I am going to we are going to see together the some of the surgical approaches of glaucoma treatment or glaucoma management, right? So surgical applications or surgical management, so how to see them, and let's zoom in the page itself. So we are present here, and let's search for the surgeries. So the surgeries we need to see here are basically, let me again point out these slides here. Basically we have to see these slides, right? So goniotomy, trabeculectomy. So goniotomy, for example, so let's see goniotomy surgeries, right? So goniotomy surgery meaning here, so let's search for goniotomy. Let's first open YouTube, then you can actually see the goniotomy changes. So let me the internet is not currently working right now. Yeah, I can actually close these two slides. You can close these two slides, right? So I can save them. Now I need to search I actually have muted myself. So yeah, so let's study the topic here. So after learning this, actually the mm, topic will get much more interesting, I believe. So let's study, and I will try to increase the desktop audio right now. So yeah, trabeculectomy. First surgery we will study is trabeculectomy.
Trabeculectomy, also called filtration surgery.
So I think the audio is visible. The audio is working right now. A buzzing sound is coming right now. Is yes, the audio is working, I think. So let's see the trabeculectomy surgery.
Trabeculectomy, also called filtration surgery, is a surgical procedure performed for treatment of glaucoma. The treatment involves removing part of the trabecular meshwork and creating a new escape route for the aqueous humor. When successful, it allows the aqueous fluid to drain from the eye into an area underneath the conjunctiva, where it is subsequently absorbed by the body's circulatory system or filtered into tears. In this procedure, a conjunctival pocket is created and may be treated with mitomycin or other antimetabolites for a few minutes. These drugs are used to prevent scarring of the operation site. Scarring, if it occurs, may clog the new drainage canal and is therefore the major reason the procedure may fail. A half-thickness flap is then made in the sclera and is dissected all the way to the clear cornea. A block of scleral tissue, including part of the trabecular meshwork and Schlem's canal, is then removed to make a hole into the anterior chamber of the eye. As the iris may plug up this hole from the inside, a piece of the iris may be removed at this time. This is called iridectomy. The scleral flap is then sutured loosely back in place. These sutures can be released gradually during a couple of weeks after surgery. This allows adjustment of the aqueous flow in order to achieve target pressure and to avoid the complication of having a too low intraocular pressure. The conjunctiva is sewn back in place to cover the area. After surgery, aqueous humor drains into a filtering area called a bleb under the conjunctiva. Since the surgery is usually performed near the top of the eye, the bleb can easily be concealed behind the upper eyelid.
So yeah, that was a very excellent explanation of the trabeculectomy. So basically the trabeculectomy shows that we are cutting a flap and cutting into the anterior chamber and making an actual pore that through where the aqueous humor can collect under the conjunctiva, and it will form actually a sac of water, so sac of the aqueous humor actually, and that will be later absorbed by the systemic circulation actually. So that was the very simple procedure of trabeculectomy in glaucoma. Now let's see the laser trabeculoplasty, which is also an interesting and important surgery.
Trabeculoplasty is a laser treatment for primary open-angle glaucoma. The laser is used to treat the trabecular meshwork through which the aqueous humor drains. In this procedure, the eye is numbed with eye drops. A special laser lens is placed on the eye to help control the direction of the laser beams. The laser burns a small area in the trabecular meshwork, opening up the drainage canal. About 50 spots over 180 degrees of the meshwork circle are treated in one therapy. The original laser trabeculoplasty procedure applies argon laser of 514 nanometer wavelength on half of the meshwork circle in one treatment. Although a second treatment can be performed on the other half of the circle, the procedure is generally not repeatable as it causes extensive scarring of the trabecular meshwork. The newer technique, selective laser trabeculoplasty, or SLT, uses a solid-state laser of 532 nanometer wavelength. The pulse energy of SLT is about 100 times lower than the traditional argon laser trabeculoplasty. SLT selectively targets pigmented cells while leaving the rest of the trabecular meshwork tissue intact. For this reason, it can be applied to 360 degrees of the meshwork in one treatment and is considered safe to be repeated. In terms of efficiency, the two techniques return similar results in lowering intraocular pressure. Laser trabeculoplasty treatment is effective in about 75% of patients. The effect may take a few weeks to kick in and can last for several years.
So yeah, that was also a very interesting approach. Now let's see laser iridotomy, I think. Laser iridotomy. So let's search for laser iridotomy.
With laser iridotomy, the ophthalmologist uses a focused beam of light to create a tiny opening about the size of a pinhead in the iris. This opening allows trapped fluid behind the iris to flow into the front of the eye, usually reducing pressure. With laser iridotomy, the ophthalmologist uses a focused beam of light to create a tiny opening about the size of a pinhead in the iris. This opening allows trapped fluid behind the iris to flow into the front of the eye, usually reducing pressure. A laser iridotomy is an important way to treat or prevent a sudden rise in eye pressure that can seriously affect your eyesight.
If you are diagnosed with narrow-angle glaucoma, your doctor may perform a procedure called laser iridotomy to decrease the risk of a sudden and dangerous buildup of pressure in your eye. Before the procedure, your doctor will place drops in your eye to constrict the pupil. Then, using a precisely focused beam of laser light, your doctor will create a tiny hole in your iris. This hole acts as an alternate channel through which fluid inside the eye can flow if the usual pathway becomes blocked. The hole will not affect your vision, and in most cases is positioned under your upper eyelid so that no one will be able to see it. Soon after the procedure is completed, you may return to your normal activities. Though a laser iridotomy is sometimes performed to relieve a sudden buildup of pressure in your eye that is already underway, it is much more commonly recommended as a preventive measure before there are any symptoms at all.
Glaucoma is an eye condition that can lead to blindness due to increased pressure within the eye. The very front of the eye can be divided into the anterior chamber found between the iris and the cornea, and the posterior chamber, a space between the iris and lens. When it comes to glaucoma, the key anatomic structures are the trabecular meshwork found in the anterior chamber and the ciliary body found in the posterior chamber. The eye produces a fluid called aqueous humor, which is secreted by the ciliary body into the posterior chamber. This fluid then flows through the pupil into the anterior chamber. From here, it drains out the eye through the trabecular meshwork. In a healthy eye, the rate of secretion balances the rate of drainage. In glaucoma, the drainage canal is partially or completely blocked, resulting in fluid buildup in the chambers. With fluid buildup, pressure within the eye increases as the fluid pushes the lens backwards into the main eye cavity known as the vitreous body. This in turn compresses and damages the blood vessels and nerve fibers running at the back of the eye. Initially, the damage results in patches of vision loss, and if left untreated, may lead to total blindness. There are two major types of glaucoma, open angle and angle closure. Open angle glaucoma, or chronic glaucoma, is caused by a partial blockage of the drainage canal. However, the angle between the cornea and the iris is open, meaning the entrance to the canal is clear, but the flow of aqueous humor is slower than normal. The pressure builds up gradually in the eye over a long period of time. Symptoms appear progressively, starting from peripheral vision loss, and may go unnoticed until central vision is affected. Progression of glaucoma can be stopped with treatments, but the part of vision that is already lost cannot be restored. This is why it's very important to detect early signs of glaucoma with regular eye exams. Angle closure glaucoma, or acute glaucoma, is caused by a sudden and complete blockage of aqueous humor drainage. Predisposing eye anatomy may elevate risk in certain individuals, but can also occur to anybody with blockage of aqueous humor drainage. Predisposing eye anatomy may elevate risk in certain individuals, but can also occur to anybody with blunt eye trauma. When this occurs, the pressure within the eye rises rapidly and may lead to total blindness quickly. If glaucoma is a concern, a tonometer can be used to see how rigid or flexible the cornea is to an externally applied pressure, which could be a puff of air or actual physical contact with a device. The lower the eye pressure, the more flexible the cornea. The higher the eye pressure, the more rigid the cornea. The eye is analogous to a balloon, where the balloon walls become more rigid with higher air pressure. Measuring eye pressures with a tonometer is routinely performed by an eye specialist.
Hi Ninja Nerds, in this video we're going to be talking about glaucoma. If you like this video, make sure to give it a thumbs up, comment down below, don't forget to subscribe. Also check out ninjanerd.org. That's where we have our notes and illustrations for you to follow along with these lectures and really get that good study habit down and really learn these concepts. Let's get into this. So glaucoma is the increase in the intraocular pressure, or the IOP is what we can call it. And this causes damage to the optic nerve. So you're probably like, what the heck are you talking about? What's IOP? What's going on? So we know within the eyeball, we have a lot of different segments, we have places, and we're gonna go through all this, but there's fluid within the eye. And fluid within the eye can increase in pressure, and pressure on certain spots can create pressure onto the optic nerve. And I'll talk about it a little more. But that optic nerve pressure eventually can lead to damage and eventually cause problems with our vision and or vision loss. So what happens? We have aqueous humor, and when there's an increase in this aqueous humor in the front anterior segment of the eye, right? So anterior segment is here, we have anterior and posterior chamber, and what we're looking at here is this increase in aqueous humor. This aqueous humor volume increases. When there's a volume increase, much like the body with the blood, when there's an increase in volume, there is hypertension. We call this intraocular hypertension, which is an increase in the IOP, and that pressure is typically greater than 21 milligrade mercury. And what we're looking at is that damage to the optic nerve, because once this fluid over here increases, then we have pressure that pushes back onto this optic nerve, and that can cause a vision disturbance and then eventually a vision loss, which is blindness. So let's go through and orient ourselves here again and talk through that so maybe we can get a little more understanding of what we're looking at. So we have our eyeball here, and we have the green outside here, which is our cornea, right? And then we have the blue, the dark blue here, which is our iris. We have the ciliary body. We have the lens, which is this big portion here, and then what we would have here is our pupil, which we can draw in just a little dotted line, okay? And this is stuff we all are probably aware of and understand what these structures are. And within this structure here, from the lens forward is where we have our anterior segment, meaning the front portion of the eye. And that anterior segment can be broken into two different portions. The anterior chamber, which is the portion in front of the iris, and the posterior chamber, which is the part below the iris or in front of the lens. Okay, so if we want to draw a little line here, this is where our posterior and this is where our anterior chamber would be. And this is mostly where the glaucoma portion of this understanding of glaucoma comes into play. But the back portion of the eye, or the posterior segment, is also really important because we have the posterior segment, so the portion behind the lens, and this whole area is filled with vitreous humor. And fluid here, as they move and bulge together, there's a problem if there's too much pressure pushing one another way. So if you picture this eyeball almost as like two balloons, there's one balloon in the front and one balloon in the back. And if one starts to fill up, it starts to push on the other one because it can't spread out this way. I mean, it could, your eye could bulge out your head. But typically what happens is it tries to keep the eyeball into your socket and it pushes back. And what happens when it pushes back, it pushes into that ocular nerve. So let's go through it again. Optic nerve, sorry. So let's go through it again. We have the increase in the aqueous humor, which means here in the front, that increases our intraocular pressure. That pressure then will push back onto our optic nerve, and that can cause a vision disturbance or loss. So you're like, where is there increase in aqueous humor? How do we just get more humor or get more of this fluid within our eye? So we have a couple more structures we need to talk about. Here, right here, is what we call our trabecular meshwork. And our trabecular meshwork is this little like drain that is over top of our Schlemm's canal. And our Schlemm's canal is this canal opening that eventually goes in and drains the fluid out of our eye and then eventually goes into circulation, right? It goes into our vascular circulation around the eyeball. And what we need to understand is our ciliary body, which is right here, starts to produce our aqueous humor. And our aqueous humor goes from our posterior chamber up through our anterior chamber, goes to drain through our trabecular meshwork and out Schlemm's canal. And we have to understand that when there is an input, right, so we have an input of fluid, we have the production, we have to have an equal output or drainage of that. So let's look at this one more time. We have a ciliary body. The ciliary body creates that aqueous fluid. And as it goes through the posterior chamber, through the pupil, into the anterior chamber, there is this place right here, which we call the drainage angle. And that's really important for glaucoma. Drainage angle is where we get the names of the different types of glaucoma. So I want you to understand that this angle here, our iris and our cornea create an angle. And that angle will allow some fluid to flow through. And then the fluid goes through the trabecular meshwork and through Schlemm's canal. And this right here is the flow of our aqueous humor, which is great. That's what we want. But with glaucoma, there is some sort of blockage or interruption of this flow, and that's where we get a buildup of pressure. So let's look at the differences between the primary open angle and the primary angle closure. Now, you're probably like, what? These are big words. What do these words mean? So we have primary open angle. And then we have angle closure. So these are the words that I start to zone in on here and really hone in so I can remember in my head. Okay, we're talking about open angle. Now remember I said the drainage angle is where glaucoma comes into play, right, for the naming. So in open angle glaucoma, open angle, meaning this angle here is open. So there's not a problem with the angle in open angle. So this is nice, it's flowing right down in there. There's a lot of space the fluid can go into. The problem with open angle is the trabecular meshwork. So over time, this trabecular meshwork, this little drain that's over top of the canal, can get stiff and get clogged. And what happens is this fluid cannot drain out as fast or as rapidly as it wants to. So now you're thinking in your head, okay, I have lots of input but no output. So because it's not draining out as fast as it wants to, there's an increase in the aqueous humor here. And because of it, there starts to press, right, some pressure here and some pressure this way. And as that pressure pushes our lens, it causes more pressure back onto the retina and back onto the optic nerve. And that pressure here, as it presses the retina up against the optic nerve, it can create some visual disturbances. And with primary open angle, because it is the most common, it also happens a little more gradually. There's usually like a mild headache, maybe some mild eye pain, very, very, very mild. There's a loss of the peripheral vision, the halo around the lights, and then the increase of the interocular pressure. So what I want you to get from this is that open angle, primary open angle means the drainage angle is nice and open, it's allowing the fluid to drain. However, the trabecular meshwork is our problem because that's where our blockage is. So because of that, we're not draining our fluid out properly and we're increasing that interocular pressure. And that increase in the IOP is causing that pressure back onto our optic nerve. Now, let's go into our primary angle closure. So this one should already give you an idea on what the problem is. It's telling you angle closure, or sometimes it's called narrow angle or narrow closure. All of these names are telling you what's wrong with it, that there is a narrowing of this angle. So if you look at this eye compared to this eye's got a lot of space, it's nice and open, right? So for a primary open angle, it looks kind of like this, right? And then we have our drainage here. But on the primary angle closure, it's a lot more narrow. And because of that, the fluid is having trouble getting into there. And this is typically an emergency. And you're probably like, well, what happens? So typically, the cause of this is either some type of anatomical defect or some type of medication that the patient is taking. So this fluid, again, coming from the ciliary body, goes up through the pupil, goes through the trabecular meshwork, but because its angle is so tight and so narrow, it's having trouble flowing out. And again, we start having troubles with the fluid draining, so we start having pressure. Because of that pressure, we get pressure back along the nerves as well and along the retina. And this is a rapid onset. All of a sudden, they're like, I don't know, this eye pain, it came out of nowhere. Their pupils might be non-reactive to light. They're saying it's severe pain. It's severe. They may get some type of nausea or vomiting. Their eyes may be sensitive to light. And then edema, you can even see it maybe around the eye. And because of all this, this is an emergency. This means that we are getting such a rapid onset that we're having trouble draining out fluid at all. And now what's going on is we are creating back pressure onto that optic nerve, and we may have some type of problem very quickly that is going to be permanent. So let's go in to talk about the assessment, the interventions, and the patient education on how we can teach them about glaucoma. All right, Ninja Nerds, let's talk about our assessment of our patient. So when we talk about the primary open angle glaucoma or the primary acute closure glaucoma, there's a couple different discrepancies between the symptoms. Even though they're both glaucoma, there is still a obvious difference between some of the symptoms. And one of them is that open angle is typically painless, where angle closure is typically severe pain. So let's go through really quickly. Open angle is painless. It usually changes slowly over time, and it'll create some sort of tunnel vision. So these patients will get that tunneling, the tunnel vision, or that cloudiness from the peripherals into the central. So this is very classic open angle glaucoma, and the angle closure will typically be a blurry vision almost all over because that pressure is so sudden with that sudden eye pain that the eye cannot even show any type of image. It starts to just get a little fuzzy, a little hazy, a little blurry. And there will be some halos around the lights. What's most important is to recognize, especially the open angle glaucoma, right away. If you do have a patient, whether you go into the room to assess them for that shift, or they come into your ER and they're saying, I just have this really severe eye pain, you want to make sure you're assessing them and getting onto them quickly, and then letting their doctor know. Once then, the doctor will be able to do some sorts of visual assessments. Now, if you're going to your eye doctor regularly, which is very important, then you'll be able to get some of this stuff routinely at the eye doctor. Some of these tests can be done very routinely. So the first one we have is the visual assessment. The doc can view the optic nerve, and they can look to see if there's any type of pressure on the nerve. You can also, as a nurse, do a peripheral visual assessment if maybe there's something going on, and you can check their peripheral vision. The other ones is, if you've ever gone to the eye doctor and gotten this test done, you'll know as soon as I tell you this tonometry, it's the measurement of the intraocular pressure. It's typically between 10 to 21 milligrade mercury. But I want you to understand is that this is the test when you go to the eye doctor where they puff the little puff in your eye. I hate it every time I go. I'm like in the machine like this, like because I know that puff's coming. But once it's done, you get to a measurement of your IOP, and that's great. The other one is the gonioscopy, which is what they use to view the anterior chamber, and again, measure that drainage angle, because remember, that was one of the defining characteristics between the open angle and the angle closure is the drainage angle, okay? So what are we gonna do if we have a patient come in or we go into the patient's room and they're like, my eye is screaming, what's going on? So typically with that primary angle closure, it's an emergency, and we wanna start administering medications that could hopefully decrease the interocular pressure. And then when it's deemed necessary, you may have to prepare the patient for surgery. Now, there may be instances where they're not going to go for surgery that day, but hopefully we're able to get the intraocular pressure under control so the damage isn't permanent and severe. So some of the choices for surgery are an iridotomy, which is the small holes that they poke into the iris, and that will help the aqueous humor flow and have a little more space and equally flow. They can also do the placement of a shunt, which would go through the meshwork, the trabecular meshwork, and be able to help that fluid drain out. They can also get what we call the laser trabeculoplasty, or the SLT. What this is the laser that goes in and causes damage to the drainage tissue, so the areas within that drainage angle. They can blast it with a laser and hopefully, make it stop accumulating, kind of help the tissues to not block our drainage angle. But over time, it's not permanent, and eventually that angle will close back down. And then we have a trabeculectomy, which is where they take the trabecular meshwork, they remove it, and then you can actually see a bleb on your patient's eye. So if you don't know what a bleb is, you can definitely Google it. It's this like little whitened area. It's above the iris, and you can see it under the eyelid. And that's a pretty common side effect of the trabeculectomy. But remember, these are whether you want to get it for your open angle or your angle closure. I mean, your open angle or your angle closure, because they can both work for either of them. There's just some that are a little more evasive and a little more strategic in the emergent setting. But we want to make sure that we are talking to our patient the education of what we can do to either prevent it before it becomes permanent. So first is the importance of the lifelong medications. If they were to have surgery, or hopefully we can prevent it prior, we want to give them certain medications like miotics, which can be constricting of the pupils, the carbonic anhydrase inhibitors, which will decrease the production of the aqueous humor, which again, if there's not as much input, then we don't have as much output to drain out. And then we also have beta blockers. And these can all typically be given through eye drops. So you want to make sure that your patient knows how to administer eye drops. We're using hand hygiene. We're not touching the tip to the eyeball. We're pulling down to expose our conjunctival sac and dropping the drops into that. And then we are able to close our eye and move it around. And we want to make sure that the patients know how to do those eye drops, especially if they're possibly going to be doing lifelong medications. And we also want them to make sure that they know that they need to keep up with it. It's not today I'm going to do a little this, tomorrow I'm going to do a little this, because that eye pressure can build up. We want to make sure that they're avoiding the anticholinergic medications. So a lot of your antihistamine or allergy medications can have these anticholinergics, which can also increase intraocular pressure. You want to tell them to wear sunglasses or anything else that they can really help with their vision. So you don't want them straining with their vision. And avoiding any type of thing that will increase intraocular pressure, like bending at the waist, coughing, straining, heavy lifting, things that will make their intraocular pressure go up. So we want to make sure that we're keeping an eye on them, especially after surgery. This is really important because we don't want them to cause any type of perforation of the incision. We want that eye to heal nicely. We don't want them to lay on their operative side, and most importantly, they need to report to their healthcare provider if they have any lid swelling, bleeding, drainage, sharp sudden pain, flashes of light, and big one here, the ankles like to hit on, the nausea and vomiting. If you have a patient that has a new glaucoma surgery and they are nausea and vomiting, they have both of those, you want to make sure that you're picking this patient out of your prioritization, because they have a chance to increase intraocular pressure, and you can just easily help them with an antiemetic if you can give them an antiemetic, because that can be controlled. The most important thing to prevention for this is their annual eye exams, and if they do have surgery, also getting the intraocular pressure measuring consistently. That way we're able to keep an eye on this patient and prevent it from becoming permanent, because remember, glaucoma is a preventable disease that is painless, but it can be permanent when left untreated. All right, Ninja Nerds, in this video we talked about glaucoma. I hope you liked it. I hope it made sense. If you did, hit a like down below and subscribe. And as always, until next time.